Peripheral neuropathy is damage to the nerves that come out of your spinal cord and go to your hands and your feet. There are a number of ways to categorize nerves, but one of the simplest ways to think about it is in 3 different categories. One is sensory nerves, and those are nerves that bring messages of pain or hot or cold or touch to your brain from parts of your body. Another type of nerve is a motor nerve, and in general, those nerves take messages from your brain down to the muscles of your body and tell them what to do. And a third type of nerve, which we don't think of as often, is called an autonomic nerve. And that nerve controls things like your heart rate or how well your gut is moving. And sometimes those can be damaged too. The most common presentation for a patient who has peripheral neuropathy is complaints of numbness and tingling. Sometimes that numbness and tingling actually feels like burning and can be very uncomfortable. For other patients, it's a loss of sensation, so feeling really numb. In some cases, patients actually have more problems with their balance because some of the sensory nerves are sending information about where your body is in space to your brain. And for those patients, they might say, well, when I close my eyes in the shower, I feel like I'm going to tip over. And that's because their body isn't sure exactly where they are in space. There are a lot of risk factors, actually. Some people think that age is a risk factor for peripheral neuropathy, but more commonly, I think of things like diabetes, alcohol consumption, and for some patients, infections. Specifically in my clinic, I think about exposure to treatments for cancer, like chemotherapy. The first and most important step in confirming the diagnosis of peripheral neuropathy is to listen carefully to the patient and their symptoms. Many times, the history will actually tell you what the diagnosis is. After listening carefully to the patient, my next step is typically to do a thorough neurologic exam, which includes examining the sensory and motor nerves. Thankfully, many times, the history and the physical examination do give us an answer. But in the case that it doesn't, sometimes we do order a battery of blood tests to take a look at vitamin deficiencies or other causes of reversible neuropathy. We don't routinely order imaging for neuropathy, but if our physical examination determines that perhaps a nerve is being squished or pushed on, then it might be appropriate to order an MRI or a CT scan. In some complex cases, we might use a nerve biopsy, an electromyogram or nerve conduction test, and in some cases, a skin punch biopsy to give us more information about why a patient is having symptoms. Once we've determined the underlying cause of the neuropathy, we can usually tailor a treatment to fit the underlying cause. Treatment options for neuropathy include watchful waiting, and that is because thankfully most patients with a chemotherapy-induced peripheral neuropathy will get better with time. In some cases, we choose to use medications. In other cases, we might use a medicine called IVIG to remove antibodies from the blood and improve a patient's symptoms. In very rare cases, if a nerve is actually compressed, we may recommend a surgery. We're here to support you through your therapy and help you and your primary oncologist make good decisions about the medications for you.